Hi, thank you all for joining us for the September Winona webinar. Once again, I am Ashley. I'm the Director of Patient Services at Winona. And online today, we have our Chief Medical Officer, Dr. Green. Dr. Green, do you want to introduce yourself?
So hi, my name is Mike Green. I'm an OBGYN. I'm the Chief Medical Officer of Winona, but more importantly for a lot of you, I'm also your personal doctor through the Winona site. And it's a pleasure to take care of you guys, and I try and do the best job I can for you. So I've been an OBGYN for 23 years now, and so I have a lot of experience doing this and sort of helped launch Winona, and it's been really exciting to be able to bring women's health and particularly relief from menopause and perimenopause symptoms online in a convenient, safe way for y'all. So these things are designed really to answer your questions. Just so you know, we are always available for you to answer your questions online. So please don't hesitate to send questions in through the portal. We really want to make sure that your questions are answered, that you feel comfortable, and that a well-educated patient is a more compliant and happy patient. And we want to be a team working with you to make sure we get things right for you. So this doesn't replace that. This is just an extra. So you can see me talk rather than just read my typing and all my spelling errors. But anyway, so to make this work, what we want you to do is go ahead and put your questions in the chat. And I'll do my best to answer all your questions as thoroughly and as well as I can throughout our time. So I usually kind of start with a little monologue to give you some information and also kill a little time to get some questions up there. So please put your questions in while I'm talking. I just wanted to talk a little bit about depression and hormone replacement therapy, because depression and anxiety, which kind of go hand in hand, is a very common problem through this menopause transition. In fact, twice as many women than men suffer from depression, and it really spikes, and unfortunately suicide spike as well during this time in a woman's life. And so it's a big deal, and it's really important. So the first thing I want to say is depression is a very serious problem, and if it gets really out of control and you start feeling like you're going to hurt yourself or someone else, you need to get more help than we can give you online. And so there's a national number. You can just dial 988, and that is a suicide prevention and task force, and there'll be counselors there to talk to you. You can also dial 911 and go to the ER if it really gets out of hand. So make sure you do that. But for most people, thankfully, it doesn't get to that situation. And there's very good evidence and some really good studies that hormone replacement therapy not only treats depression, but it also prevents depression. In one study, there were 50% of the women there were 50% fewer women that were depressed or that became depressed who were on hormone replacement therapy than women that were not on hormone replacement therapy. So not only does it treat the depression, but it also prevents depression from happening in the first place, which really is even better. And so that's one of the bonuses of hormone replacement therapy, I think, that people don't talk about very much or really understand, but it is a fairly good antidepressant. It works several ways. It works directly on the brain. The estrogen particularly can increase serotonin, which is basically how most antidepressants work, and so help treat your depression directly. But it also treats a lot of causes of depression and things that exacerbate depression. So women that aren't sleeping well, that are up all night, that are with their hot flushes or other reasons, hormone replacement therapy can help get you a good night's sleep, and being well rested and having a good amount of sleep is a really important treatment for depression. It also can help with some of the big mood swings that can happen, and really stabilize moods and treat depression that way. And also, in menopause, a lot of times there's a lot of body changes. We've talked a lot about the weight gain that happens in the middle, but also skin and hair changes. And those body image changes can also lead to depression and exacerbated depression. And hormone replacement therapy helps treat those underlying causes as well. So there's a lot of avenues in which it works for that. And I don't think it's really brought up enough. So that's just one more benefit for some women that hormone replacement therapy can give. So I think I've talked long enough. We've loaded up enough questions. We can answer your questions instead of mine.
We have a lot of questions.
Yeah, that's great. Otherwise, I'm just going to be standing here yakking.
Oh, that never happens on our webinars. Okay, so the first question is from Paulia. Can low hormones cause anxiety at night?
They can, and that sort of goes along with what I was just saying. Depression and anxiety really go together, and a lot of times it's hard to tease out which is which, because it's really a continuum, and it's not one or the other. And so just like hormone replacement therapy can treat depression, it can also treat anxiety. And yes, low hormones can definitely cause anxiety at night and during the day. But certainly at night seems to be more common, and it definitely can help that, yes.
Okay. The next question is Elizabeth. Is it normal to continue night sweats the first few weeks on HRT?
I'll tell you how great of a question it was. That was something I was thinking earlier today. Maybe I should talk about that instead of depression to open up with. So thank you. I got to pay you the $20 to ask that one, huh? So, and I've been getting a lot of these questions with patients. It's probably my fault if I am not explaining it well, or we haven't done a good job on the site explaining it well. One of the major reasons that women experience hot flushes are very rapid changes in estrogen levels. And so what happens during the perimenopause and menopause transition is that the hormones don't just sort of nice and gradually start making less and less hormone. What happens is they become really inefficient. And so they don't make hardly anything, and then all of a sudden, boom, they spike out a big spike of hormone, and then they don't make anything again. And the overall, if you average it out, it's less and less hormone, but it's really spiky. And we think it's those spikes that particularly cause the hot flashes, those rapid changes in estrogen levels. And so hormone replacement therapy works. One of the ways it works, not only does it raise levels to where they should be, but it also smooths out those spikes. And so your body isn't seeing these big changes in hormone levels because you have this sort of baseline normal hormone level already. And that's one of the ways it treats hot flashes. The other thing is that a lot of times post-menopausal women, so years after menopause, hot flashes eventually go away, and that's because the ovary isn't making any estrogen anymore, so there's no spikes at all. So it's important to understand why hot flashes occur, to understand what happens in this first couple of weeks. So for some women, if their levels are particularly low, we add back estrogen and those levels rise. And it doesn't really rise perfectly smoothly. I wish it would, but it really doesn't. And so there's a little bit of spikiness until you get a nice steady state and everything levels out. And that rise and those spikiness is really the same mechanism that can cause hot flashes. So occasionally you have a woman who never had any hot flashes at all, and they start, their hormone cream, and for the first 2-3 weeks, all of a sudden they're getting hot flashes, and they get really mad. It's like, I never even had hot flashes. Now you're giving me hot flashes. And I understand that would be annoying, and I'd probably be mad too if I didn't understand it. But that's really a mechanism of just getting that level up to where it needs to be. And then once that level is a nice steady state, the hot flashes will stop. So that's a pretty long answer for your simple question. But yes, it's pretty common to have night sweats and hot flashes in the first few weeks of starting treatment. And it can also happen when we change dose. So if we get you on a dose and we decide, well, you know what, you probably need a little more estrogen, and we raise that dose, there may be a short time where you go through the thing all over again, unfortunately. But that's the mechanism. And I think if you understand what's going on, it makes it a little bit easier, but at least it does for me.
Okay. Next one is from Lynn. Hi, everyone. I just started my treatment this week. Does it really take up to 3 months for relief? The hot flashes are unbearable sometimes.
So for most people, it doesn't take 3 months for relief. Most people get some relief pretty early on within the first few weeks. What happens is that some things are sort of like the hot flashes, for instance. Once you get through that initial couple of weeks, they usually get better, or at least substantially better, and then they kind of continue to improve over time. There are other things, like weight loss in particular, that can really take a while. Vaginal changes also tend to take longer. So some things take longer than others, and then some things are unpredictable. And honestly, it's all a little bit unpredictable because it's amazing to me how different each human body is on how they respond to medications. But I don't expect you to be suffering for 3 months. I expect you to have some relief, usually after the first few weeks. Some women get really lucky, and like the first couple doses, they feel great. But for most women, it takes a couple of weeks. Then they start feeling better. and then that slowly and gradually builds. The 3 months is really, that helps me judge where we're at. So by 3 months, not completely, but we've mostly gotten the benefit that we're going to get out of this particular dose. So that's why I like to check in about 10 weeks after starting treatment. It's about a week before your next refill's due. So it gives us some time to talk and get this right before the refill gets sent out, in case we need to change the dose. Because by that time, I can tell pretty well where you're at and where you're going. And so if by that time, things aren't really better, then we probably need to adjust the dosage. If you adjust the dose too early, what happens is you end up on a much higher dose than you need. And one of the guiding principles really in all of medicine is we try and keep people on the least amount of medicine necessary to take care of the problem. So I don't want to sort of get too carried away and you end up with more medicine than you need. But relief is coming. Hopefully sooner rather than later.
Okay, the next one from Deirdre. 2 questions. 1, does DHEA affect blood pressure? 2, can taking DHEA mid-morning assist with mid-afternoon slump?
So good questions. Any of the hormone replacement therapy can affect blood pressure. It's pretty rare that it affects blood pressure to the point that it becomes a problem. DHEA gets broken down into estrogen and testosterone. The estrogen contribution is pretty small. It's there, but it's pretty small. We're really using it for testosterone. And we're using it in low doses so that we're not pushing the testosterone to like bodybuilder levels. So really the idea is to get your testosterone to sort of, your normal values, kind of where it was before you were going through this menopause transition, to get you feeling better. So we're not, pushing this thing, to get you ready for the Olympics or something. And so the amount of hormone that you're getting from the DHEA contribution is pretty small. And so, yes, it's theoretically possible for it to raise blood pressure, but it's pretty unusual for it to raise blood pressure enough to be significant or to be a problem for people. Once in a blue moon, you have somebody that's really sensitive, but honestly, it's pretty rare. And then, so DHEA is really kind of funny in how people respond. So I would say that the majority of people don't get an immediate boost from DHEA. It's more of a cumulative effect. As the drug levels get up, they end up with more energy through the day. You get the weight loss, you get the libido changes. Those take some time, but it's not really, for most people, it's not a stimulant where, like coffee. Like, I'll be honest with you, I overdid it on the elliptical today and I was pretty tired. And so I had a cup of coffee before I started with this because I knew the caffeine would help get my mind sharp for you guys. DHEA doesn't really work that way. It's not really a stimulant. Now, this is where it's funny, because I've had patients, and that's why I tell people, take it whenever you can remember it best, because it doesn't seem to be dependent on when you take it. But I've had patients tell me, gee, I take the DHEA in the morning and it just knocks me out. I'm tired. It's like, okay, take it at night. And occasionally I have people take it at night and say, well, it keeps me up. So, okay, take it in the morning. So for some people, it will act that way and it may get you through a slump period. But I don't think that's the majority of people. I think for the majority of people, it's more sort of behind the scenes, slowly and gradually working kind of throughout the day, rather than sort of a spiky gives you a boost kind of thing. If that makes sense.
Okay. As long as we continue BHRT, do we not transition into menopause from peri? I'm 49, 3 months in, and feeling great. The thumbs up emoji.
All right. Well, I'm glad you're feeling great. You can see my deformed thumbs, but so the answer is no. And this is a common question I get, actually. There's nothing that's going to stop you from going into menopause and from aging. I mean, it'd be nice if we could fix this, but we all have the same fate eventually, ashes to ashes and dust to dust. But, and we can't really stop that. But what we can do is make life a lot better while you're getting there. And that's what this is really about. So menopause happens because the ovaries become less and less efficient over time and eventually stop making hormone. Actually, menopause happens before the ovaries completely shut down. So they stop getting to the point where they can ovulate or make enough cycles to give you a period. And so it's this sort of gradual process. Hormone replacement therapy does not change the efficiency of the ovaries. It doesn't change the way the ovaries are working. What it does is it supplements the hormones that the ovaries were supposed to be making, but just aren't good at anymore and aren't making them anymore. So those ovaries are still going to be decreasing in their efficiency and decreasing in their hormone output, and eventually they're going to go kaput. It's just that the hormone replacement therapy supplements those hormones to keep you feeling well while that transition is happening. But menopause is still going to happen whenever it's programmed in your body to happen, and this isn't going to stop that. It's just going to make you feel a whole lot better while it's happening.
Okay, next one is from Heather. How will I know if my dosage is correct long term?
Okay, another great question. And we sort of answer this every time, which I'm glad for, because this kind of leads to the whole question of how do we figure out your dose and how do we know that you're on the right dose? I'm a big picture guy. I've always been a big picture guy. And I, believe it or not, considering I'm the chief medical officer of a tech company, when it comes to medicine, I really back away a lot from technology. In fact, I just had this conversation with some family practice residents I'm training this week, kind of giving them a hard time for stuff they wanted to order. A patient comes in the ER and they get what I call an electronic pelvic exam. Before anyone even looks at them, asks what's going on, or lays hands on them, they get sent to the CT scanner. I just don't think that's a good way to do medicine. My experience is talk to the patient, see what's going on, and that's usually going to guide you what you're going to do. And that's how hormone replacement therapy is. Hormone replacement therapy really is symptom driven. And so the way I know you're on the right dose is, number one, your symptoms are controlled, and number two, you're not having side effects. If we've done those two things, we've got you on a pretty good dose. I know if I push the dose too high, eventually you're going to get side effects. So if you start developing side effects, that tells me, hey, maybe we got the dose higher than it needs to be. If, on the other hand, yeah, I'm kind of better, but I'm still not where I want to be, it's working, but it's not really working that much, or gosh, it feels like I'm not taking anything, then we don't have you on a high enough dose and we need to increase the dose. The other thing that happens is that the dosage need can change over time. So what can happen is, you're going along and we got you're 49. So your ovaries are, kind of starting to not work so good. And so we're replacing your hormones, but we're not shutting your ovaries down. This is the difference between birth control pills and hormone replacement therapy. Birth control pills shut the ovary down. They're designed to stop the ovary from making anything, and they completely take over the hormones of the body, female hormones of the body. That's not what we're doing here. So we're adding back hormones, but also taking advantage of the hormones the ovaries are making. And over time, as those ovaries become less and less efficient, they're contributing less and less hormone. And so there may be a time where we need to bump your dose a little bit. And this happens. I've got people that have been on a good dose for 6 months or a year, and all of a sudden, gee, I'm getting hot flashes again. It's like, well, it sounds like your ovaries are making less hormone. We need to add back a little bit more. Honestly, that happened to my wife. She was super happy. And then all of a sudden, like, her period stopped, like the ovaries just shut down, and all of a sudden she's getting hot flashes again. We had to up her dose. Now she's happy again. And that's normal. And so that's the way we monitor the dose over the long term. The two simple questions really, is it relieving your symptoms? Or are you getting side effects? And if it's not relieving your symptoms, we need more. And if you're getting side effects, we need less. The tricky thing is when it's not relieving your symptoms and you're getting side effects, then sometimes we have to play around with this medicine or sometimes change the way you're taking it. But for most people, it's really pretty simple. And then there may become a time where it's really not needed anymore. And so, at some point, it may be worth a trial off of it and see how you feel. It's kind of funny. It's not funny, haha, but it's interesting. I get patients that tell me, this isn't doing anything for me. Please stop sending me medicine. I'm like, okay, no problem. Hope everything goes well for you. And then 3 months later, I get a message saying, I feel miserable. It was doing a lot more than I realized. Can I restart the medicine? And so it's reasonable. I would say, depending on your age, if you're 49, I'd give it a few years because you're going to need it for a while. But at some point, you might want to, maybe 3, 4, 5 years down the line, when there isn't something important coming up, go off of it for a month or two and see how you feel. And if you feel the same, you probably don't need it anymore. And if you're miserable, or don't wait till you get totally miserable, we can restart it. So it's a reasonable test to do.
That was a good question. Okay.
I kind of packed a lot of information in there.
Yeah. Okay, from Megan. Question is, of course, since menopause, I have belly fat. Does that indicate estrogen dominance? And if so, is it still helpful to use both estrogen and progesterone? I used both during perimenopause and they were a huge help. Thank you for doing this for us.
Okay, so I'm going to let you in on a little OBGYN secret. The term estrogen dominance is a trigger word for us OBGYNs. We want to slice our wrist when we hear that. No offense to you guys, because I understand people are talking to you about this. But this idea of estrogen dominance doesn't really come from the scientific literature. So it's not something that in the medical field that we really talk about. And so none of us really know exactly what you're talking about when you use this idea of estrogen dominance. From an OBGYN, my idea of estrogen dominance is that your inside lining of the uterus is seeing too much estrogen and putting you at risk for cancer. And so there are certain states that can do that. PCOS is one of them, where the environment in the uterus is really an estrogen dominant environment. And so we need to make sure you have enough progesterone to protect the lining of the uterus. So that's sort of the medical place where we use that. There's certain other conditions, but PCOS is by far the most common. But really, that's the area where we worry about too much estrogen or estrogen dominance is the lining of the uterus protected? Because that's where it comes back to bite you. Nobody in menopause or nobody that's having perimenopausal symptoms doesn't need estrogen. And so this is something that I try not to argue with patients online because it's not really helpful. But this is something I think there's a big misunderstanding. It's the estrogen that's causing the symptoms. Progesterone helps a little bit with some things, but it's really along for the ride. And the progesterone is used in hormone replacement therapy to protect that lining of the uterus. It's not really used for symptom control. Now, progesterone does help. It can help with sleep and it can help some with mood. It's not just totally dormant. But there's also a downside to progesterone. And so even if there's this idea of estrogen dominance that is sort of pushed around, on the internet and wherever, it's really a younger person's issue. It's not a perimenopause issue. So if you're having perimenopause symptoms, that's from estrogen. It's because you don't have enough estrogen there. And so the treatment is going to be to add back estrogen. If you have a uterus, we need to add progesterone to protect your uterus, but it's estrogen that's doing the heavy lifting, and to some extent the testosterone, and that's what we use DHEA for. I just went down this huge rabbit trail and I forgot what the question was really about. I apologize. See, you triggered me.
Do you want me to reread it?
It was the belly fat question, right? I'm sorry.
No, it wasn't the belly
fat. I actually answer your question.
Okay. So the first part was, does that indicate the estrogen dominance? And if so, is it helpful to use both estrogen and progesterone? I've used both during perimenopause and they were a huge help.
Okay, so if you have a uterus, you need both. If you don't have a uterus, you need estrogen. The progesterone, you probably don't need. Occasionally it's helpful. My recommendation is to try the estrogen without the progesterone first, because the fewer medicines we have you on, the safer it is for you. Adding progesterone is not an unreasonable thing to do in somebody, even if they don't have a uterus, if we find that the estrogen isn't going to be doing enough to take care of their symptoms. But again, if you've got perimenopause symptoms, if you've got symptoms of the menopause transition, if you've got symptoms, it's the estrogen that's really going to be helping you, and maybe some progesterone depending on the situation.
The next one is from Wendy. If I am presently on a compound cream, can it be replicated?
Replicated by another, I assume you mean replicated by another pharmacy.
Yeah.
Well, I know what you're saying. Okay, I got it now. Someone else is giving you a cream and you want to know, can we make the same cream? So the yes and no. Can we make the same cream? Yeah, probably. It's kind of got what's in it, and it's not completely secret recipe. Will we do that? No. And unless it happens to be a cream that we already make. And the reason is really, there's multiple reasons for this. And actually, we just had a meeting yesterday morning with the big pharmacy staff, including the pharmacists and sort of the bosses and stuff. We do that once a month because it's really important that we communicate well with our pharmacy team. And we were talking about this, and they say that they were saying that they've got doctors that prescribe these like incredibly crazy mixtures with a little bit of that, a little bit of that, a little bit of this, a little bit of that, and like really complicated. And they have other doctors that like write the same cream for everybody, and they haven't seen a difference in how happy patients are. And I told you I'm a big picture guy. I can tell you that this may make some of you unhappy, so maybe I shouldn't say this, but I watch these personal trainers at the gym putting people through like 15, 20 different exercises. I go to the gym and, I do, if I'm doing like a full body, a full upper body day, I do biceps, a triceps, a chest, a back, and a shoulder. That's it. And then I do some cardio when I'm done. And honestly, that's all you really need, to get in shape. You don't need like 10 different bicep exercises. I mean, now, if you're Arnold Schwarzenegger, or you're competing for, Miss World or Miss whatever the Miss Universe, that's a whole different thing. Okay, yeah, you need 100 different exercises to target that teeny itsy bitsy muscle over here that you can't get otherwise. But for most of us, a handful of exercises, a little routine, and I've got a couple of different exercises for each body type in case somebody's on the equipment that needs this one, that works. And I think it's the same way with hormone replacement therapy. You need estrogen. You're going to need most women. All women need estrogen when they come to me with perimenopause symptoms, or pretty much all of them. Most women are going to need some testosterone. That's where the DHEA comes in, and you may or may not need progesterone. And then the question is, how much of this stuff? And so it's sort of small, medium, and large, quite honestly, is the way I see it. And then you need a safe ratio so that things are balanced correctly. And so we have these sort of small, medium, and large safe ratio creams that we've developed that work really well. And so I have one I can think of specifically that came from Europe with this like horrendously complicated cream, and she was pretty upset that we wouldn't do it. And I said, try one of these. I think you'll be happy. And she just wasn't happy before she even started it. So I get it. But on the other hand, it puts a lot of strain on the pharmacy. And so one of the things we're trying to do is we want to get you taken care of and get you feeling better. We want to do it safely. That's the number one important thing. Okay. But we also want to do it as inexpensively and as easily for you as possible. And so one of the ways we keep costs down is by having sort of certain small, medium, and large formulations that we can batch and squirt in several different bottles rather than having our pharmacists have to concoct each thing with a million different recipes individually. And that goes against what a lot of people do out in private practice. And I think some of it is the personal trainer thing. Look, if they can make it complicated enough, you can't go somewhere else because no one's going to be able to duplicate this thing. And that's not, I don't think that's right. I want to do what's right for you, what's going to make you feel better. And if someone else can duplicate it and you'd rather do that, that's okay. And I've had patients, I remember I had a patient who was a Kaiser patient, and she came to me and said, my doctor said, I don't prescribe HRT, period. So she had no access to HRT. So, we got her going, and she felt great, and she was on a patch. And after about 3 months, she sent me a really nice note thanking me, saying how wonderful it was, but that when her Kaiser doctor saw how much better she was and how she felt better, he agreed to write it so she could get it free through her Kaiser program. And you know what? I felt good about that. It's like, great, I educated a doctor that HRT is okay. So, I'm here to get you taken care of and to get you feeling better. I'm not here to sort of put on a show. And that's one of the things when we developed this was, you'll notice onboarding is very simple. And I really, really worked hard. I developed those questions, and I really worked hard to ask everything I need to know to safely do this, and nothing that I don't need to know. When you come to an office, you fill out a giant pack of stuff the first time you come in. I don't need to know your child immunizations to prescribe HRT. I don't need to know that, you got bit by a dog when you were 6 and had surgery on your leg. It's just not going to help me make a good choice. So why ask you all those questions? And so we're trying to develop something that we can keep costs down, that we can provide really high quality care without wasting your time, and making it simple and easy for you. And that's really sort of the big thing. And so, our pharmacists are great. They could duplicate anything, but that's not really what we do. So I hope that's okay.
I think that was a great answer. Okay, moving on to Megan. Approximately how long could it take for the full effects, and also for weight loss to happen? 3 months, question mark?
Yeah, so 3 months is a good benchmark. By 3 months, we have a pretty good idea of where you're going to be. So I would expect, the table to have turned. I use that train analogy when people are trying to lose weight. It's like, gosh, I've been gaining weight. Now I want to lose weight. Well, the first thing we got to do is change that from gaining weight to not gaining weight. So we've got to slow down that train and stop it, and then we can reverse the train. And that takes time. And so by 3 months, we should start seeing that train reversing. And if we're not, then it may be that we need to adjust the medication. You're not going to have lost all your weight by 3 months, unless you only have a couple pounds to lose. But you should be at least starting to see progress. And then we know, okay, we're on the right track. We can continue to ride this out and get benefits. So 3 months isn't going to tell you, I'm done. But 3 months gives us a pretty good idea, this is working, and this looks like the dose we need to get you where you're eventually going to need to be. But it's a long, steady process.
So this next question's a little bit longer, so feel free to get some water while I read this out.
Perfect. Read my mind.
From Shelby, how do you know the correct dosage, whether it be by pill, cream, or patch? How is the consistency of consistency of dose in each? Also, should I have blood work done to measure my hormone levels? How do I choose what products will help me now, and how may it change as my hormones change? Okay, so it's about a 3-part question, and feel free to ask me when you need the next part.
Okay, no, great question. Some of it, I think the last part we kind of covered, but we can hit it again. You probably typed the question in before I completely answered the other one. So the correct dosage, here's the way it worked. I've been doing this for a long time, but honestly, in an office, you talk to the patient, you write a prescription, you don't really think that much about it. And so I developed an algorithm at first, and that's what gives you, so the recommendation that happens on the onboarding is an algorithm that I developed based on different symptoms and what helps those different symptoms. And so we started with this algorithm, and then I started watching it pretty critically for the first 500,000 patients that came through, and we kind of tweaked it. And by then, we had it pretty good. And I can tell you, it's pretty rare for a patient to come through where I change the recommendation from the algorithm. Usually it's because I uncover some information that the algorithm didn't get. Either somebody misanswered something or what have you. But it doesn't happen very often. So I got that down pretty good. So for those first 1,000 patients or so, I was still prescribing the same way. I'd look at everything, choose a dose, and then prescribe that. And then what I started doing is I started thinking critically, like, what is making me choose this dose over that dose? And so every time I chose a dose, because look, after you do something for 20 years, you just intuitively know what doses you need. And so, that's honestly the way most people do it in practice. Is patient comes in, you kind of know what to do, and you write the prescription. But I wanted this to be reproducible as we started hiring other doctors. And so I started thinking critically, what is it that's getting me towards this dose over that dose? And I started kind of unraveling that intuition because that intuition is really based on information that my brain is processing without me consciously thinking about it. And so I started thinking about that and unraveling it, and then I was able to come up with an algorithm for the dosage as well. So the algorithm for which medicine was fairly easy. The dosage took a lot longer, and it took a lot more work, honestly, for me, just because I had to unravel subconscious processes to figure out what's driving me to this dose. And eventually I got pretty good. And so what happens behind the scenes is you see the algorithm that gives you the what medicine, you need this or you need that. And then the doctor basically, there's a second algorithm where when the doctor comes on, it gives us a suggested dosage. And that works pretty good too. It doesn't work as well as the onboarding algorithm, but it doesn't have to. And so every once in a while, I'll change the dose on that, and so will the other doctors. And I tell all the doctors I hire, look, this is a suggestion. I am not telling you how to practice medicine, because I hire people because they're good docs. And, I want them to feel that they have the freedom to change things around. And so sometimes we'll change the dose based on what we're seeing. But that's how the sort of behind the scenes magic works, is that it took a lot of thinking on my part to figure out how was I dosing this sort of in real life, in the office, and getting that into an algorithm that spits out a pretty consistent dosage. That's how it all works. And I think it works pretty well. I can tell you that, and I purposely underdose people because I would much rather, I get some of your symptoms under control, but I don't completely nail it, then I cause you misery with a bunch of side effects. So the dose is always kind of a little bit less than you probably need. But most of the time I get it right. But when I don't, it's usually, we need to increase this a little bit or that a little bit. It's pretty unusual where we need to decrease the dose. It does happen. It doesn't happen as much. Okay, so that was one part. Sorry.
Okay. How is the consistency?
Blood work.
Oh, no. Oh, yes. I'm sorry. Blood work should I have my blood work done to measure my hormone levels?
Okay, anyone who's watched any of these knows how I feel about this already, and you guys are rolling your eyes going, oh, here he goes. So there's a ton of literature that blood work is not necessary for hormone replacement therapy. There was a editorial in the New England Journal of Medicine a couple years back, saying, please stop ordering blood work for hormone replacement therapy. It's completely unnecessary. It's a huge waste of money. It's very inaccurate. Hormone levels are all over the place from day to day and even in the same day. And so a spot level of a hormone level of an estrogen or a progesterone, or God forbid an LH, which is really useless, doesn't tell you anything. And some of you have had that experience. You've gone to your doctors, you feel miserable, they've done hormone levels. They're like, well, your hormone levels are fine. I'm not going to give you HRT. And then you find your way here and we provide it for you. And it's like, wow, I feel better. It's like, yeah, because hormone levels don't work. And there's really no reason to do them at all. There's some really occasional rare things. If you're 30 and you go through menopause, something's weird, that needs to be looked at, because that's so far out of the normal that, there may be something genetic going on or what's happening. And honestly, that's why we don't take women under 35, because, if you've had surgery and your ovaries were removed, okay, that's fine. But if you're having menopause symptoms at 30, 31, that's so far on the one side of the bell curve that it really deserves an evaluation. Is there something else going on? But for the normal person of a normal age, between say 35 and 59, that's having these symptoms, it's like, well, we know where the symptoms are coming from. We know how to treat them. There's no reason to do blood levels. And so I think last time or the time before, I made this analogy to my experience on blood pressure medicine. So, I don't know, it's probably 6 or 9 months now. We were screwing around on labor and delivery, checking each other's blood pressure. And mine was so high, the nurses wanted to send me to the ER. I'm like, you can't do that. You need me here on the floor. And so they were like on stroke watch all night. So I started blood pressure medicine. Nobody did a blood test to see if I needed blood pressure medicine. I had a symptom, and that symptom was my blood pressure. And I got put on blood pressure medicine, and I followed my blood pressure at home, which was my symptom. And the blood pressure medicine got adjusted to treat my symptoms. And nobody did a blood level to see if my beta blocker was high enough, because that's not how it works. You adjust based on symptoms. And so, like, we all kind of know that for blood pressure, or if you have high blood pressure, you know that. Sure, there are blood tests that get done, but it's nothing to do with your blood pressure. Those blood tests are to see, did the blood pressure cause other problems we need to look at? Are your kidneys okay, and that kind of stuff. But they're not for adjusting dose or choosing a dosage for the blood pressure medicine. And so hormone replacement therapy is the same thing. There's just no reason to check blood levels of these things because they're not accurate. They don't honestly help. The other unfortunate thing is, lab tests have become this billion-dollar industry now. And there's all kinds of companies pushing their lab tests online and trying to entice you to do blood tests. And then you get these like crazy results. The fertility ones are really bad. I've had people call me in a panic. Oh my God, I was at the fair and they did this. Oh my God, I bet it was some place that wants to do more labs and more testing on you. But it's the same with these hormones. And so these tests are really not helpful at all. And I can tell you the saliva tests are really out there. So, don't do tests for hormones, but if you're gonna do them, don't do the saliva tests. Those are complete garbage. They're just a complete waste of time. I have a patient who, someone gifted her these saliva tests. She has surgical menopause, she's got no ovaries. She's not getting progesterone, and her progesterone was really high. It's like, well, where'd that come from? Because you don't have anything in your body that makes progesterone. We're not giving you any. These tests are really not helpful, and they end up misguiding, and you don't get the treatment you need because the tests tell you everything's normal, even though your body's screaming that it's not. And so, really, symptoms is the right way to do this.
May I piggyback on that blood work test question? I've seen a lot of over-the-counter menopause tests that measure FSH or TSH levels.
FSH.
Explain those.
Those are really dangerous, in my opinion, because here's what happens. And actually, I'll tell you a funny story about this. And I know it looks like I'm probably just trying to eat the clock, so sorry, I'm just talkative today. But the problem is, you go and you get one of these tests and it tells you that you're in menopause, and you're not, because the test is garbage. And so you go off your birth control because I don't need it on my menopause. And then guess what? You have an unintended pregnancy. And that's a big problem. And it happens. So I had a patient that I saw in the ER. She came in, she didn't have a doctor. And she went to one of these health fairs that told her that she was infertile. It wasn't the same FSH test. It was another test that told her she was infertile. And she came in she went off her birth control and she got pregnant. She had an ectopic pregnancy, and I took her to the operating room and she lost her tube and some blood. And she had a hospital, so it was a big deal. She had surgery over this, all because she had some bogus test that told her that she was no longer fertile when she was. So these don't trust these. Honestly, if you're going to choose one test, an FSH on cycle day 3 occasionally can be helpful, but it's not necessary. It's just absolutely not necessary. This is why do it.
Okay, so the last part of Shelby's question was, how do I choose what products will help me now and how it changes as my hormones change?
So yeah, we sort of talked about this. So the products are based on your symptoms. So there are sort of, estrogen symptoms, there's testosterone symptoms, there are some progesterone symptoms, and then the cluster of symptoms and the amount of symptoms and where they're coming from, and and your history and a bunch of other things all goes into dosage and choosing which product is going to be best for you. When it comes down to the cream, the patch, or the pill, the truth is they're pretty interchangeable as far as efficacy, how well they work. They all work fine. There's some theoretical reasons why the patch and the cream is a little bit safer than the pill. And for some people, that can be important, but for most people, it's not a big issue. And so it comes down to cost and preference. So for women that need both estrogen and progesterone, we can compound it into the same cream, and that ends up being the least expensive. And it's kind of a nice way to do it. So that's by far our most popular treatment modality, but they all work fine. And it's kind of funny. Every now and then I'll have somebody who is on one thing, the pill or the patch or the cream or whatever. It doesn't seem to be working for them. And so I just change them. So I'll go from the pill, let's try the cream, and all of a sudden, wow, it works better. Or they're on the cream and I change them to the pill and it works better. And I don't know why that is. I don't have a good explanation for that, and it's not always in the same direction. It just seems that for some reason, some people's bodies respond better to one thing over the other, but it's not predictable. And most people, the majority of people, will do well, whichever way you want that. So really, that comes down more to convenience and personal preference and cost, as far as choosing which way to give it.
Okay, the next question is from Alma. I started BHRT 3 weeks ago and I feel irritated all the time, like PMS 24/7. Is it normal? Hate feeling this way. I thought it was going to be better with BHRT. Sorry, Alma.
Yeah, so there's a couple possibilities here. For some women, they're just sensitive, and kind of hitting them with the normal dose all at once doesn't end up being the best way to go. Of the medications, the DHEA tends to be the culprit here, but sometimes I don't know if you're on the cream or the pill, but sometimes it's the estrogen or progesterone, but it's usually the DHEA. So I usually recommend stop the DHEA for a little while. If it's really bad and you want to, and you're on the cream, you can go down to 1 pump for a week or 2, then gradually work your way back up to 2 pumps. Once you're feeling better on that for a couple of weeks, and your body now seems to have adjusted to the hormones, then go ahead and restart the DHEA. It's just a more gradual approach. Doing it that way takes longer to get the symptoms under control. But if you're feeling terrible and you're irritated and that's not good. And so if we can make it gentler, even if it takes longer to get to the pot of gold under the rainbow, it may be worth it if the journey's better. So that's a thing that you can do. Most people do fine just sort of hitting them with the normal dose right away, but there's a reasonable minority of people where we need to kind of go a little more gently and go a little slower. So that's what I would recommend doing. It won't hurt you. It'll just take a little bit longer to get your benefits, but if it gets this under control, then it's probably worth it. The truth is, if you just muscle through it, eventually it's probably going to go away, but there's really no reason to do that. The nice thing about hormone replacement therapy, it's never really an emergency to start your hormone replacement therapy. And so if it works better for you to start gradually and just take a little bit longer to get your reward, but feel better while you're doing it, that's probably worth doing. And that's what I would recommend.
Okay. Shelby, my mom has been in Premarin forever. It's not even prescribed much anymore. Is this a replacement similar to Premarin? If yes or no, why and how?
Okay, so I always like to tell the Premarin story. So the word Premarin comes from 3 words. Pregnant, that's the mare or horse, urine, Premarin. So Premarin means pregnant horse urine, and that's literally where they get the estrogen from. So they have these horses, they keep pregnant, and they collect their urine, and the urine is really high in horse estrogens, and then they're able to get the estrogen out of the urine, they turn into a pill, and they give it to women. And it's okay, it doesn't, it does the trick for most people. Before, and that was one of the early estrogens that we had. So just from a technological point of view, it was sort of this really novel way of getting estrogen in a pill form that you could give women. And so Premarin was really the standard estrogen. It's all we really had for the most part. In the 90s, I started practicing in 99, 90s, early 2000s, Premarin was mostly what we had. And then it went along with something called Provera, it's still around. It's a synthetic progestin. So a progesterone that's synthetic is called progestin, but it's a progesterone, but it's synthetic, so it's a progestin. And so we used to give Premarin and Provera was sort of the classic hormone replacement therapy, and it worked okay. Had a lot of side effects because it turns out that horses' estrogen isn't the same as women's estrogen. Works okay, but it's not perfect. And so eventually people started developing these bioidentical hormones, and so we've developed the hormones that are exactly the same as what your ovary already makes. And those just work better than horse estrogen because it's what your body's used to see. And so, unfortunately, there's still old guys like me around that haven't learned their lesson, and they're still writing for Premarin and Provera because it's all they know. And so they just write their Prem Pro or their Prem Phase or the Premarin, and because it's what they've always used. And that's kind of too bad. I've always said I don't want to be the first person in the city using a new product, but I don't want to be the last one either. If I'm doing the same thing I did 23 years ago when I got out of residency, then I'm not a good doctor anymore, because medicine has gotten a lot better in 23 years, thankfully, and we need to keep up with the times. And so Premarin is sort of an old school treatment. It was great when that was it. You know, it was like, wow, this is a breakthrough. And it was really great for women because we had something that helped. But fortunately, technology has moved on and we've developed things that are even better. And so to me, Premarin is kind of old school. It doesn't really, there's just no reason to prescribe it anymore. And so that's why we've pretty much replaced Premarin with these bioidentical estrogen products that work. They just work better. And they have less side effects.
Okay. The next one is from Noelle. I see many HRT doctors recommend progesterone for half of the standard cycle, 14 days. Winona prescribes it continually, full cycle. What are the advantages to both approaches?
So great. That's a really good question, and it's another complicated question. So there's a couple of reasons that people do it this way. The bad reason is they think they're mimicking the natural cycle, which is baloney because it's not what we're trying to do. So we don't want big fluctuations in hormones. That's what gives you symptoms. The reason that people get PMS is because of these changes, big changes in hormones just before the period. So why do that to you on purpose? Doesn't really make a lot of sense. And so people that do it because they're trying to mimic the natural process don't really understand what they're trying to accomplish, because what we're really trying to do is come in underneath the ovary and supplement what the ovary isn't making anymore, and the ovary isn't making that anymore the whole cycle, and so you really need these hormones throughout the cycle. So in my opinion, because of that concept, you get the best results, people feel best when you're giving this daily. So that's one big advantage. The second big advantage is it's a whole lot easier to do. I think ease is really important, because if somebody is doing something, taking your medicine consistently, that's going to work a lot better than somebody that forgets to take medicine. The medicine doesn't work when it's sitting in the, in the cupboard, right? That's what I always joke about why condoms don't work, because they don't work when they're sitting in the nightstand, and that's where they end up. And it's the same thing with any medication. So the simpler we can do it, make your life easier, and the more likely it is for you to remember to do it, the more likely you're going to get benefit. So I think just, even if in a perfect world where you could do it perfectly, you're still going to get more benefit from doing it daily. Number two, it's easier for you, so why make it more complicated? And again, I'm kind of a big picture guy, and I like to try to use a big picture approach, and I don't sort of micromanage. I don't micromanage my doctors. I don't micromanage my patients. And I think it works better that way. So the other reason that's not wrong, so I think the reason of trying to mimic the natural cycle is wrong, but the other reason that's not wrong has to do with the Women's Health Initiative study. And there was an interesting result that came out of that study saying that women that were on only estrogen did not have an increased risk of breast cancer. Women that were on a combination of estrogen and progesterone had a slight, not very much, but a slight increased risk of breast cancer. And so people said, well, gee, progesterone must be the problem. And so we should try to limit how much progesterone people are getting to try to limit their exposure, of this thing that may be giving them breast cancer. The problem is that no one's really shown that works. So doing this 14 days on, 14 days off, there's no real data that actually decreases your risk of breast cancer. So it doesn't accomplish what they're going after. The other thing is that I think there's a compounding variable. I haven't been able to prove this, but just logically, it doesn't make sense to me that adding progesterone would change breast cancer risk, because it's usually estrogen that's a culprit anyway. So why is that? And the only women that got estrogen without progesterone were women that had hysterectomy. So you already got a totally different population of women. And I think maybe there's something else going on in this different population that changed those numbers. Can't prove it, don't know for sure. But doing this 14 days off, 14 days on thing doesn't seem to really change anybody's risk factors. So it doesn't help what people are going after. And the other problem is that if you're not getting periods, doing that will almost guarantee that you get a period. And so, I have patients that tell me the only good thing about menopause is I'm not getting periods anymore. and now all of a sudden you're going to give me a period? What do you think? And so that's the other problem with that approach, is that, all of a sudden, yeah, you make it more natural, but it's kind of nasty natural. It's not what people every now and then I have a patient that says, I want a period every month. It's like, okay, and for those people, we'll use some kind of approach like that. The other thing is that can sometimes help people that are having irregular periods. But again, it's a pretty rare situation where I think that's really a useful way to go. And I think the vast majority of people do just as well, if not better, taking both hormones every day, which makes it simpler and easier to do. So those are the reasons that Winona has chosen to use the daily combined approach rather than this intermittent approach to the progesterone.
Okay. Elizabeth said, awesome explanation. Laurent said, I just upped my cream dose from 3 pumps after 6 weeks, parentheses, after checking in. When should you consider a higher dose again?
Okay, so it depends on if you have just an estrogen cream, the 3 pumps is the same as the increased dose, but it's going to cost you more money because so here's another little thing that I learned that really surprised me. All the expense in these creams is from the cream. The hormones actually don't cost like hardly anything. So increasing the amount of cream we give you increase costs, and we have to charge you more. Increasing the amount of hormone in the cream, so going from 3 milligrams per ml of estrogen to 5 milligrams doesn't really cost us that much more, so we just don't increase the price. So if you're finding that 3 pumps is better, then we can, when that starts running out, we can increase the dose in the cream, so you can go back to 2 pumps and save you money. The other thing is that if you have a combination cream, these ratios change. So there's a sort of a basic amount of progesterone we need in there to protect your uterine lining from the amount of estrogen we give, and those ratios can change. And so it's okay, it's safe, and it's okay for the short term to kind of mess that ratio up a little bit. But once we get that established, then we like to get you back on the appropriate ratio. So it depends on which kind of cream you're getting. You're either getting too much progesterone if you're using 3 pumps, or not enough if you're using 1 pump. Neither is going to hurt you in the short term, but in the long term, we like to get that back to where we think is the ideal place. And, so why put you on 3 pumps in the first place? Why not just send you a new tube of the appropriate dosed medication? And really the answer is because I'm cheap. And if it was me, I wouldn't want to throw out perfectly good cream. So, we didn't raise our kids this way, but I'm still from the clean your plate, clean your plate or no dessert or no TV. And, that's a really bad habit. I do not recommend raising your kids that way, but, that's kind of what it is with me. I don't like wasting. I don't like telling you to waste. If I was on your end, it would make me mad if I had to throw out half a bottle of perfectly good cream. So this is a way for you to use up what you have without wasting it. And then we can get you on a more efficient dose. So the answer really is that when you have about a week left, let your Winona doctor know so they can send you a refill, and remind them that you're using 3 pumps. You can send her a refill of the higher dose cream so you can go back to 2 pumps, and the cream will be the same price.
Okay, the next question is from Sarah. I already do BHRT for 4 years. I switched to this cream and I'm having a lot of hot flashes at night.
So we're probably underdosing you. We probably need a stronger dose. And so I would message your Winona doctor. If that's me, you can say, you told me to message you. Or if it's one of the other doctors, don't say, Dr. Green said to message you. But, let them know, hey, I switched creams and I'm having hot flashes I didn't have before. And in that case, it may be that we need to increase the estrogen content in your cream. That would be the most likely thing.
Okay. The next question is from Rachel Stevenson. I just started taking estradiol and DHEA about a week. I've been noticing weight gain. Is this normal? I'm needing to lose weight, not gain weight.
Yeah, people hate this. I hate it. I wish it wasn't true. Water weight is pretty common when you first start these hormones. And, sometimes it's obvious. Like, I don't know about you, but I got on the scale and it says something I don't want. I always see, how's my ring fitting? And I hope I can't get it off. Just full of water. because weight fluctuates with water weight by several pounds, throughout the day and day to day, just from moving water around. Sometimes it's not that obvious, but there's still some water weight on. So weight gain that happens right away like that is almost always just from some water retention. That will go away, but it kind of sucks because you're doing this because you want to lose weight and the scale's going the wrong direction, and nobody likes that. But that does go away. If you're really having a water retention problem, you can use an over-the-counter diuretic. We are close to having a diuretic that we can prescribe you, hopefully in the next few weeks to a month. But right now, we don't. But an over-the-counter diuretic to knock off some of that water is a reasonable way to go. That will go away on its own with time, but it's frustrating. I get it. If it's the other thing that happens, and I'm not saying this is you, but it doesn't happen very often, honestly, because people are smarter than this. But occasionally they think, oh, I've got this magic pill. I can eat whatever I want, and I know it's going to make me lose weight. And that's just not the way it works. So, you can't all of a sudden decide, okay, now that I'm taking hormone replacement therapy, I can eat like an 18-year-old again. No, that's not going to work, and you're going to gain weight. So you still need to do the hard work. You still need to exercise. You still need to diet. Diet's not a good word, but you still need to change your lifestyle and your eating habits. The real trick is to change your eating habits in a way that's sustainable. It's a lifetime change. That's the problem with diets. Unless you're trying to get into a dress for, a wedding in 6 weeks, going on some crazy diet just isn't going to work. You're going to gain it right back. So you really want to find something that's sustainable, but you're still going to have to do the hard work. What this is going to do is it's going to help make that hard work much more efficient and work better for you. And I think for most of us, more importantly, is it's going to change the distribution of where that weight goes. So, when women are young, they tend to get that hourglass shape. And so a few extra pounds, kind of makes them look a little bit better. But as they go through this menopause transition, the metabolism changes and the fat storage changes, and all of a sudden the fat's going in the middle where nobody wants it. And so this does help make those metabolic changes. That is something that's a process and takes a while. That's one of those things that takes a few months to really get, but it does help move the fat away. The other thing is that particularly the DHEA can help increase your muscle mass. And so this is more of a long-term problem, but occasionally I'll have somebody say, look, I'm watching my calories, I've been hitting the gym hard, I'm doing weightlifting, and my weight's not going down or it's gone up a little bit. And I ask them, how are your clothes fitting? It's like, oh, actually, yeah, they've, dropped a size or two or whatever. It's like, well, what's happening is you're going from fat to muscle, and that's actually going to weigh a little bit more. But for the most part, you're going to look better and you're going to feel better and you're going to be healthier. And so that kind of weight gain is pretty good, but you're not getting that in the first few days or a few weeks. That's really more of a long-term issue. So those are, I really went down a rabbit trail on that, but those are all the issues that accompany sort of this weight journey.
Okay. Next question is from Sarah. As our ovaries decline and sputter out, we will adjust dosage over time. I see this as a long-term support years as I age.
So it's kind of an interesting thing. What happens is hormone needs will go up with time, and so we'll have to increase the dose, and then eventually it goes the other way. And the body will require less hormone, and eventually we can decrease it. And eventually, for a lot of people, they can go off of it completely. There is a timing issue with hormone replacement therapy that's becoming better and better understood. And that is that starting it earlier gives a lot of health benefits that you don't get if you wait until later. And so this early start, I was just reading an article today. Actually, I was prepping for this. I was reading articles on depression. And even in that, they were bringing up the early start, how important that can be, because it does not just treat, but also prevent depression. And so there, even for that, starting earlier rather than later is going to be healthier. And eventually, for some people, they don't need it anymore, and there's no point taking a medicine you don't need. These aren't vitamins. It's not like taking vitamin C you can take forever. These are medicines, and they have risks. The risks are small, thankfully, and for most people, the benefits are worth that risk. But if you're not getting any benefit anymore, there's no point taking them. First of all, they cost money, so there's that. But you want to do in my opinion, you want to be on the least medicine you need, but medicines can really change your quality of life and improve things. So you might as well do that.
Okay, the next question is a little bit longer, so feel free to get some water. I am 47 and I have finished a 6-month I'm so sorry. I've finished a non-stop period. Doctor told me I may be perimenopausal. She gave me some pills to take for 12 days with progesterone, I think, to flush out my system. My other doctor keeps pushing Prozac, but I am reluctant because I am not depressed, anxious, yes, but not depressed. Plus she's pushing birth control pills. I thought I left that years ago. Can I do hormone replacement therapy before I'm in menopause? Do I really need to take birth control pills?
So, yeah, that's a great question. So birth control pills work pretty well at preventing pregnancy. That's why they call it birth control pills. And they also work well for cycle control. And they do both of those things much better than hormone replacement therapy. Hormone replacement therapy does not provide contraception. So I always try to make that perfectly clear because I don't want a mistake where somebody thinks, oh, I'm taking hormones, I can't get pregnant anymore. And then, they have a oops. So we don't want that. So if you need contraception, then that's the reason to take birth control pills. Occasionally, birth control pills can also be used for cycle control, and they can work pretty well for that, better than HRT. But if you're having menopause symptoms, they don't work that well for menopause symptoms. They work okay. They probably help hot flashes, but they don't work for all these other things. And the reason is they use synthetic estrogens and progestins. And again, as I mentioned before, they work completely differently. They're designed completely different than HRT. They're designed to shut the ovary down and take over control of your hormonal axis. And that's how they keep you from getting pregnant. So they give you hormones back and keep your ovary from making any hormones so that you don't make eggs, which is great if you don't want to be pregnant. But those hormones aren't the same as your normal hormones, and they don't act the same. So the lazy doc, I was talking to a guy in the operating room a few months ago, and it just kind of ticked me off because he's like, oh, I just put everybody on birth control pills and take them off when they're 60 and I don't have to worry about it. And I'm thinking, that's a really terrible way of doing it. But it's a lazy way of doing it, and it's not the right way or the best way. It probably keeps people out of his office, but it's like, that's just not the right thing to do. So I think that HRT can help a lot more than birth control pills. So the Prozac thing, SSRIs, Prozac is one of those, can help with hot flushes. Doesn't work as well as estrogen, but it can help some. So there are some people that are just deathly afraid of prescribing HRT, and so they come up with all these other things they can use, like birth control pills and Prozac, to try to get a hold of your symptoms. The funny thing is that birth control pills is a much bigger dose of hormones than HRT and has way more risks than HRT, but they're used to prescribing birth control pills and they're not used to prescribing HRT. So it's sort of the easy, lazy way to do it, and they feel like they're doing something good. I think you'd be an excellent candidate for hormone replacement therapy. The only caveat is the bleeding that you had for 6 months. I assume somebody looked into that with an ultrasound or a biopsy or something to make sure there wasn't some other reason that you were bleeding. So once you know that the bleeding is really just hormonal and there isn't something going on, there isn't a problem in the lining of the uterus or a polyp or something that needs to be treated, then I think hormone replacement therapy has a much better chance of treating your perimenopause symptoms than birth control pills do. So you don't have to wait till you're in menopause. In fact, it's a mistake to wait until you're in menopause. As I said earlier, there's this timing issue. And we know that the earlier in perimenopause you start these medications, the more health benefits you get. It helps you decrease your risk of cardiovascular disease, which is the number one killer of women in the world. It helps decrease your risk of osteoporosis. It helps decrease your risk of depression. So there's all these benefits that you get that, forget about treating your symptoms, that you get from starting this well before you wait until you're truly in menopause. On top of that, you're having symptoms that can be fixed. So not only are you getting health benefits, but you're getting quality of life benefits. So it's really a mistake to sort of put it off. Well, I'll just muscle through this. I can get through it. Well, of course you can get through it, but why would you want to? So you might as well feel better and be healthier and take the medicine. So I think you probably, assuming the bleeding has been evaluated, I think you'd be a great candidate for hormone replacement therapy.
Okay, next question's from Cassie. I'm the same vein as Sarah's earlier question. Would taking BHRT when you're having periods once or twice a year, would it kick it back into having your monthly cycle? It sounds like you may have answered this question with the difference between birth control pills and BHRT. I am 50 years old now and have been in perimenopause for 2 years.
Good question, and I didn't really answer that, so let me answer that specifically. So for most people, hormone replacement therapy is not going to change whatever your periods are destined to be. It does sometimes make them a little bit better, but it shouldn't restart periods when you weren't getting them. The caveat, the first month or so, sometimes 4 to 6 weeks, it may trigger an initial period, and that's annoying. So you start them, and 2 weeks later, all of a sudden you've got a period and you haven't had one in a long time, and it's annoying. Or it may give you some spotting that first month, and that's annoying. But once you get through that, that shouldn't happen. And if it starts happening, then we worry there's something else going on. So apart from once you get out of that first month, maybe 6 weeks, your periods are going to go back to whatever they're normally going to be. In your case, spaced out pretty far and eventually probably stopping. And the other way this can mess up your periods, if you forget to take it, so usually a day you're okay, but you forget 2 or 3 days, that can be enough to trigger a period for people. So it kind of punishes you if you forget, so try not to. But apart from that, no, it shouldn't all of a sudden start giving you regular periods again. As I said earlier, for a lot of people, that's like the one benefit of this menopause transition is all of a sudden these annoying periods aren't happening so often, and people like that. And again, every now and then I have somebody I need a period every month, and it's like, okay, we can do that too. But, if that's what you want, God bless you. I'm not sure why you'd want to do that, but I'm not you, so not going to judge. We can help you with that too.
Next question is from Sue. I'm 11 years past menopause, had pellets of testosterone last year and liked it, but can't find a doctor where I live now who will help me. My skin has started thinning and my sex drive has diminished. Can Winona help?
Yeah, absolutely. So we have a lot of sort of pellet refugees. You actually like the pellets, but the pellets, it's a pretty invasive way of doing this. I honestly am not sure why pellet therapy has become so popular. It's kind of sexy and glamorous because you're having this invasive procedure, but on the other hand, someone's shoving a big needle into you and depositing a foreign body underneath your skin. And the problem is, if it works, man, it's great. You do it once, it works, you feel great. If it doesn't work, or you have side effects, or you don't like it, you're stuck with this thing for 3 to 4 months, and there's no way to get rid of it. So the nice thing about more traditional hormone replacement therapy like cream is that we can, change the dose on the fly if we need to. Like the previous person, they found that, they were having personality changes they didn't like, and I suggested, well, let's back off and do it a little bit more gently, and you can do that with pellet therapy. You can, and it also doesn't have the risks that pellet therapy have. You're not going to get an infection, you're not going to get an hematoma, you're not going to get problems that we sometimes see with pellet therapy. And so for a lot of people, it's a nice replacement. It's not going to be the same as pellet therapy. I think it's going to be better because you probably don't just need testosterone, but you also need some estrogen. And so we'll be able to give you a more balanced approach and help your skin, help other symptoms. Sometimes symptoms you don't even realize you're having because you've been living with them, and so it just sort of became part of daily life. So yeah, I think we can help you.
Okay, next question is from Lynette. How can I tell if my symptoms are being caused by perimenopause or just stress? My main symptoms are weight gain, mainly abdominal, fatigue, moodiness, low libido, and acne around my mouth and chin.
So that sounds much more hormonal than it sounds just stress related. That's kind of a classic cluster of symptoms that people see in the perimenopause. The honest truth is, only really way to know is to try it and see if it helps. And there's a pretty good chance that this is from your hormones, and we add back some hormones, and all of a sudden these things start going away and peeling off, and you feel better, and you're like, okay, it was my hormones. Or we may get 3 months into it and it hasn't done anything, maybe adjust the dose and it still doesn't do anything, and it's like, well, maybe I was wrong. Maybe it was stress. But for the vast majority of people, this does help. But it's one of those things, there's no way to know 100% until you try it and see. But the symptoms that you're describing sound a lot more than just stress. And that cluster of symptoms specifically is the classic cluster for perimenopause.
Okay. And the next question is, Rhonda said, good to know about estrogen dominance. Thanks for asking that question to me again. Jessica had said,
Sorry, you launched me trigger.
Jessica said, I've been on an antidepressant and anti-anxiety meds for over a year now. Once the hormones kick in, will I be able to wean off those medications?
Possibly. I would be careful about that. And I would do it, whoever's prescribing those medicines, I do it under their guidance. What I don't want to happen is, you think things are going well and you dump the medicines and all of a sudden you have a big crisis, and that can be a big setback for you. So yeah, hopefully this will be enough that you can back down off those medicines, but there's a safe way to do it. And quite honestly, as a gynecologist, I'm not the person to manage those medicines for you and work with you on how to peel them off safely. It's not my area of expertise. And the last thing, again, my number one priority is safety. If I get rid of your hot flashes and I cause you some grave problem, I haven't done you any favors. So, safety is always number 1, 2, and 3 before anything else. And I think there's a really good chance you'll be able to diminish or get rid of these medications, but you don't want to just stop them on your own. You want to do that, through the help of your doctor that's prescribing them.
Okay. And the next one is from Annette. Hello, I will get my libido back after being on treatment for more than 3 months. I do not see any changes with that desire coming back.
So libido is tricky, and it's almost never one thing. It's almost always multifactorial. The medications and it's sometimes, a lot of times, part of that is a decrease in hormones, and getting those hormones back can help in a lot of ways. Number one, just physiologically, can drive the libido by bringing your hormones back where they should be. It can also help if you're having, say, vaginal dryness or discomfort with sex, and that gets taken care of because, I don't know, if sex hurt me, I wouldn't want to have sex very often. So getting rid of that, it can be an underlying reason. You may not even thought of it that could be driving libido issues. Furthermore, body image issues can certainly do that as well. So all of a sudden your body doesn't look like it used to. You don't feel sexy anymore. Maybe even your partner's telling you, no, you still look great, but you don't believe them. Because the way you see yourself in the mirror is honestly more important than the way someone else sees you. And so body image problems can drive libido as well. And so as your weight starts coming off and gets, you start getting rid of some of that belly fat, and your skin starts improving your hair and you start feeling more beautiful, the libido can come back. But that's a process and can take a long time. But there are also other reasons for libido that have nothing to do with your hormones. Relationship problems, stress, kid problems. Someone told me, I think it's a great saying, you're only as happy as your least happy child. And so, there's all kinds of things in your life that are going to affect your libido. This hormone and the milieu that happens around the perimenopause that gets fixed or at least improved with hormone replacement therapy is certainly an important part. And for a lot of people, it's enough. But for some people, it's not the only answer. And there are other things to explore. So the first thing I would do would be, are you on a dose of medicine that, this should take care of it if it's a hormone issue. And so maybe we need to increase your DHEA, or maybe we need to increase your cream or whatever. But once we get you to that and you've been on it long enough, if the libido is still not coming back, it's time to explore other issues. Is there some anxiety that's holding you back? Is there stress? There may be other issues going on in your life that you aren't even thinking about that are affecting it. So it's a complicated issue. This is one part of it.
The next one is from Rachel. I've been using hormone replacement cream for about a month now. I'm going on a hiking trip next week and want to avoid having my period at that time. Is it safe to supplement the progesterone products? Norethindrone?
Yeah.
to stop my period temporarily for this trip while on the hormone supplement cream.
It is. Next week, though, you may have missed that window. Although if you hurry, so yes. So one way to avoid or put off a period is to take progesterone. And if you get it early enough, it can stop that period from happening. And then as soon as you stop it, within the next 7 days or so, sometimes right away, sometimes a week out, something like that, your period will come. So this is a reasonable way to do it. Our 25th wedding anniversary, my wife and I went to Italy, and she was supposed to have her period that week. So I gave her some medicine. I gave her progesterone to keep that from happening. So yes, that's something that works, and it's safe to do, and it's not going to mess up your HRT. So you can do that. You better hurry though, because if it's only a week away, there's not a lot of time here. By the way, I have done this for some patients. We can, if you've got something like that, I can send you a prescription, like a one-time prescription for progesterone pills. We have micronized progesterone, which is actually a little bit more gentle on your body, I think, than like a progesterone like norethindrone that you can take to avoid a period. I'm happy to help you with that if you just message me. But it's too late for a week from now. We won't be able to get you the medicine in time. So if you've got a supply, use that.
Okay, so the next one, I'm sorry, Megan said, I appreciate the simplicity and cost. My scripts in the past were 3 different creams and the 3 different doses, and were almost $200 per month. Aww. Okay. Next question from Noelle. To the patient asking about weight loss, my experience was within 2 weeks, I feel less agitated, more energetic, and sleep better. At the 4-month mark, I've dropped 12 pounds with modest effort. Oh, not a question. That's great.
That's great.
Okay. Shelby says, I have a better understanding. Karen says, what causes belly fat in menopause? Minobelly? Question mark. So
yeah, it really has to do with metabolic changes. And so as the hormone levels drop, the estrogen, particularly, and the progesterone, and to some extent the testosterone, but more the estrogen really drives where the deposition of fat goes. And nobody really knows exactly why this is, but it probably has something to do with childbearing. And better places to store fat, so that, you got to remember that, well, depending on your point of view, we either evolved or were designed to survive in an environment where there wasn't enough nutrition. It's really only in very recent human history, in the last 100 years, not even that long, where, at least in the United States, we're in a situation where most people can get enough calories on board. And most of us, fortunately, can get way more calories on board than we need. And so food has become incredibly easy and convenient to get to. But that's not the environment that we were created or were evolved for. And so we evolved in an environment where food was scarce and protein was scarce. And, we had to withstand famine, and we didn't have big food stores. And so our bodies developed a process to be able to store calories in times of excess so that we could draw upon it in times of need. And that's what fat is all about. And so really it's the healthy person with good genetics that's able to store all these extra calories into fat. In the 21st century, it's a bummer, but until recently, that's why your ancestors survived, so that you could end up being here. And so one of the changes that happen as the hormones go away is that where this fat gets laid down really changes, and it doesn't change in a healthy way. And it's not just visual, but it also increases risk of other issues. And I don't know. I honestly haven't researched this out, and I don't know that any really. It's always hard to tell the why. But what is the advantage of having fat going into for women, going into your hips and into your breasts, rather than going into your belly. But that advantage gets lost as the hormones go down, and you start putting fat into areas that aren't as healthy or as desirable. So it really has to do with the metabolic changes that occur with the drop in these hormones. And so that's why getting the hormones back to sort of normal youthful levels helps change that metabolism and get the body back into the type of shape that is, that we consider desirable. And that's really how it works. And that's why it works. But I'm not smart enough or haven't researched enough to know exactly what the anthropomorphic, advantage was to laying fat down in your youth in these areas. I'm sure it's there, and I'm sure somebody understands it. It's just, I don't, sorry. but that's where it comes from.
Okay, next question from Renee. I started HRT about 6 weeks ago, and as of this week, my body is blown up. I can barely get my clothes on. My bras are too small, and my breasts are super tender. I have so much water retention. Will this go away as I continue?
So the water retention will go away. And like I said earlier, if you want to, there are over-the-counter diuretics that are gentle that you can use to knock some of that water off and feel better, and that's perfectly acceptable. The breast tenderness may or may not go away. So breast tenderness is pretty common early on, and it's really from the estrogen. But if it continues, if you're at 10 weeks and you're still having breast tenderness, that's a sign that we maybe overhit you with the estrogen and we may need to back down off the estrogen a bit. For most people, it goes away before that point. But, if you tell me at 10 weeks, gee, my breasts are really tender and it hasn't gotten better, the answer is going to be we probably need to decrease the strength of your medication. We're probably giving you too much estrogen. So that's one of those side effects that helps adjust that dose. At 6 weeks, I think there's still a reasonable chance over the next month this is going to improve on its own, but if it doesn't, that's going to be the answer. If you're really miserable, you could cut down your dose now. If you have pills, you can break them in half, or if you have cream, you can go down to 1 pump and see if that improves. If you're on the patch, you're kind of out of luck, because don't cut the patch. It messes up the delivery system. So that's one of the downsides of the patch, actually, is we don't have as much play in it to change the dosage if needed.
Okay, next question is Kristen. Do you prefer patients to message their prescriber and not the pharmacist because the Winona pharmacy is more of a fulfillment center?
So we're one big happy team. So it's not that I don't want you to book the pharmacist because they're a fulfillment center, because they're not. These are some of the brightest people I've ever worked with, but they're not physicians. And so you really want to ask us because we're the ones that all they can do is message me and say, hey, your patient's having this problem. It's like, okay, I'll message them for you. Thanks for letting me know. But they can't change your dose. They can't even give you really medical advice. They can skirt around it a little bit. So pharmacies do have a little bit of autonomy that way. But really, you want to talk to your doctor, because we're the ones that can, really give you advice. And that's our area of expertise. If you ask me questions about how mechanically, like they actually do the compounding itself, I don't know, some magic occurs and these creams spit out. That's their expertise. And so that's really what we're here for. And so please message your prescribing physician, because we're the ones, and when we have the power to change things, and we've got the experience and the expertise to help you.
Okay. The next question is from Ellen. Can you talk more about symptom differences between low estrogen and progesterone?
So, as I said earlier, almost everybody needs estrogen. That's really, for almost all of this, that's the root cause to the symptoms. Progesterone is primarily used to protect the lining of the uterus. There are some things that progesterone does help with. It tends to, for most people, it makes them sleepy. And so it can help with sleep issues. Estrogen also helps with sleep issues, but progesterone can help a little bit more sometimes. It can also affect moods, alongside estrogen as well. So you do get some of that benefit out of it. But most of really what's doing the work in hormone replacement therapy is estrogen. The DHEA is contributing to testosterone, which also helps, but in sort of a different manner. But really, for most people, it's estrogen that's doing most of the work. And if you've had a hysterectomy and you have a uterus, you'd probably do just as well on estrogen alone as well with estrogen and progesterone. But with a uterus, you need the progesterone. So it's interesting. If you take estrogen without progesterone and you have a uterus, your risk of uterine cancer is really high. It's scary high. It's wrong to do that. But when you take estrogen and progesterone together, your risk of uterine cancer is lower than people that are on no hormones whatsoever. So it works so well at protecting the uterus that it decreases your risk of uterine cancer below that of the general population. So it's actually one of the advantages of hormone replacement therapy when it's done correctly.
Okay, next question is from Shelby. Why is the patch, in my opinion, quite a bit more expensive than the cream?
It's because the patch costs us more. So the cream we make ourselves. We make it from starting products. Pharmacists make it. I don't make it, but we make it in our own pharmacy, and they start from these powders of the hormones and the base cream, and they mix them together, and it's really an art form. These guys they're amazing at it. They're really good at it. But they do all that work in the pharmacy, and that makes it pretty inexpensive. The patches we have to buy from a wholesaler, and they're expensive. And so even the generic patches are expensive for us, and so we have to pass that cost on. So it really is just it's really what does the product cost us to make or obtain, and the patches are really expensive to get on the wholesale market, and the cream we make ourselves. So that's really why there's such a big difference in cost.
Okay, so the next question is, blood tests should be checked annually, however, for cholesterol levels, not for hormone levels. Is a side effect of HRT potentially high cholesterol?
So HRT can increase cholesterol levels for some people. It's unlikely to increase it enough to make a difference, quite honestly. The creams and the patches, so giving it through the skin, has a much lower effect on cholesterol than the pills do. But the truth is, for most people, it's not going to make or break it. So if your cholesterol is a problem enough that you're going to end up needing medication, it's unlikely that the hormones are going to make it so bad that you wouldn't have needed medications without it. So yes, it may raise cholesterol a little bit, but for the vast majority of people, it doesn't raise it enough to really be an issue.
Okay. The next one comes from Christina. I came to find that my progesterone levels are really low. Is it something I should be worried about? I'm 28, not pregnant anytime soon. I have a regular period, sometimes might not have for 5 months. Oh, 28.
So yeah, this is not a hormone replacement therapy question, but still it's an important question, obviously. And I'm happy to try to help you with this. So yeah, your ovaries aren't working properly. And if you're only having periods every 5 months, you're not ovulating, or at least you're not ovulating very often. Now, don't be like that lady I talked about that ended up with an ectopic pregnancy. It doesn't mean you can't get pregnant. You can still get pregnant, okay? So don't throw away your birth control because the guy on the internet told you that your ovaries aren't making eggs. They're probably still making some eggs, and you can get pregnant, but it's going to be difficult. And so this is something that needs to be managed. There's two issues going on. The first is the non-pregnancy issue. So I doubt that the vast majority of people that are in this situation are not because their progesterone is low, but actually the estrogen is the inside lining of the uterus isn't seeing enough estrogen. And so you actually end up, I'm sorry, I got that backwards. No, it's the opposite. I've been talking too long. So it is that the estrogen, it's not necessarily the progesterone is too low necessarily. It may be that estrogen is too high, or maybe that it's too low. But the scary thing here is that if you're not menstruating more than a couple times a year, that lining may be getting too thick, and that can be a risk factor for a precancer or eventually a cancer. In my opinion, someone in your situation should be getting a period minimum every 3 months, unless you're on medication to keep that from happening. And so there's a couple ways to do that. You'll want to talk to your doctor about it. One is to hit you with some progesterone every 3 months, and that will get you a period. But if you don't want pregnancy, then it's probably better just to put you on a birth control pill that's going to take control of your cycle, or not necessarily a birth control pill, any birth control method, hormonal. So the IUD, a pill, the Nexplanon, all those things will protect your uterus. So that's a really important thing, is uterine protection. If the issue is that you want to get pregnant, there's a whole other layer of this. And there's some medications that are pretty simple and pretty inexpensive that may be enough to help you get pregnant. Clomid is the most common one, clomiphene citrate, and that's pretty easy to do. It doesn't require, fancy stuff or, invasive things. It's not going to give you, Octomom. You guys probably don't know what that is. At 28, you probably don't know who Octomom is, but it's not going to give you, a litter of babies. And it's a safe and easy approach. So those are all things that your doctor can help you with. But the good news is this should be fairly easy to fix if you're trying to get pregnant. If you're not trying to get pregnant, it needs to be adjusted so that you don't have a risk of a precancer or cancer of your uterus. So you do need to get this taken care of, but it should be fairly easy to do.
Okay, Dr. Ian, feel free to grab some water. I'm going to handle this next question. Will this be available to watch later? So as a general rule for all of our webinars, I personally always post them on the women's group within 24 hours of it being live. And then on YouTube, we send it to our video editing team and they shorten it up and clean up some of the footage. So we're not just saying and pausing, and then it's on YouTube about a week later. Okay. Also for the women's group, I went ahead and dropped the link to join in the chat. So feel free to go to that. The next
By the
question.
way, yeah, do that. That is super helpful. What do we got? Like several thousand people?
Oh, actually, we are about 75 people away from 30,000.
Wow. These are people that are in the same boat as you. It's a really helpful community. It is moderated, so there isn't any hate shaming or anything like that going on. It's really just support and talking about various experiences. I think it's an amazing thing, and I think it can be really helpful. So I would really encourage you to do that. Sorry for the little pitch.
Okay, the next question is from Claudia. If you are in peri and still cycling, would you want to take both progesterone and estrogen all month?
So yeah, I kind of covered this before. So I'll make this more brief. But there's more than one way to do this. But in my opinion, the best way to do it is to take the same amount of medicine every day, all month long, whether you're menstruating or not. Again, this is different than birth control pills in that we're not trying to take over your cycle. We're just trying to supplement what your ovaries aren't making. And your ovaries aren't making that all month long, so you need that supplementation. And if you don't get it, you're just not going to feel as good. And so it's in my opinion, it's more effective, and it's also easier to do it that way. So it's sort of a double bonus.
Okay, the next question is from Sandy. I got on here late, so not sure that this will get answered. I think she actually dropped.
It's your lucky night. My wife's in the back like wanting dinner. So.
Maybe she'll see this on the recording. I saw someone else ask if periods start up again. I haven't had one in over 3 years.
So occasionally this may trigger an initial period in the first month or so. After that, it shouldn't happen. And if you haven't had a period in 3 months and all of a sudden you're getting periods apart from that first month, that's a problem. I need to know about that. And it probably needs to be looked into. Occasionally this can uncover a problem that was there and you didn't know about. Maybe there's a polyp or something else going on and that just sort of sat there dormant, and then this uncovers it. And so you don't want to just ignore that. That's going to need to be looked at. Exam, ultrasound, maybe a biopsy to make sure everything's okay. But it really should not restart your periods unless there's something else going on. Or if you forget your medicine. So forget the medicine for 3 or 4 days, there's a pretty good chance it's going to trigger a period. So it does punish you for not doing it right.
The next question is from Manisha. She said, thank you, Winona. I'm 5 weeks in and feeling great. A question from DMK. Should you take or have to take DIM with your BHRT to balance out your hormones?
So yeah, DIM and these other supplements are safe to take, but for most people, once the Winona medicines, the HRT kicks in, they're just not needed anymore and they become a waste of money. But it's okay to continue them for a little while. It takes a little while for these medicines to really kick in. But once they kick in, I think you're going to find that they're not necessary. I think we may have missed a question.
Did we miss a question?
Sarah?
Look again.
It says, do we ever need
we need to take a break from daily DHEA?
And the answer is no, unless there's issues going on. So for most people, taking it every day for as long as you need it is totally appropriate and safe and works well. Occasionally, people will have some kind of reaction to it and need to take a break from it. But again, symptoms will drive that. So as long as everything's going well, keep taking it. There's no reason to stop it.
Okay. So that was the last of our questions that we had in our time. I know there are some more in the chat, but unfortunately we are over time by quite a bit. So I'm going to go ahead and take all the questions that are remaining in the chat, add them to a spreadsheet, and Dr. Green will report answers for those over the next few weeks, and they'll be posted to our social media. As always, we do these Q&As once a month, and we post reminders about them on Instagram in the Winona Women's Group. So please come back and join us and think of more questions.
And also, don't be shy about asking those questions to your Winona doctor. So we're happy to answer those individually through the portal as well.
Okay. Well, I'm going to go ahead and end the event, but have a great night, everyone.
Great. Thanks a lot. Thanks, you guys.